So why is this important? There are many clinical trials that have read out in the early stage setting that have completely transformed the way we think about early stage lung cancer. Adjuvant targeted therapy with the ADAURA trial, we know that osimertinib is already approved. However, recently we heard an overall survival update, which I'll share with you. We have 2 approvals for adjuvant immunotherapy, EMPOWER-010 looking at adjuvant atezolizumab, as well as the PEARLS trial or KEYNOTE-091 looking at adjuvant pembrolizumab. Both of these are approved and available. And the neoadjuvant chemoimmunotherapy, CheckMate 816, also FDA approved for 3 cycles of chemoimmunotherapy before surgery. And now we have 2 additional clinical trials that have read out, which use perioperative immunotherapy, that is pre and post, so neoadjuvant as well as adjuvant, AEGEAN and Keynote 671. So let's just go through many of these trials now. About 3 years ago, ADAURA read out at ASCO 2020. This is a phase 3 double-blind clinical trial for patients with 1B to 3A non-small cell lung cancer with either an exon 19 deletion EGFR or L858R, only those 2 sensitizing mutations. Patients had to have had surgery and then were randomized. They could have received chemotherapy. They didn't have to. And they were randomized to either receive osimertinib or placebo. And the primary endpoint was DFS, as you can see on the right. Significant improvement with a hazard ratio that was 0.17 for the stage 2 and 3A population. So this led to an approval for osimertinib in December 2020, which made it really important for us to test for these patients in the adjuvant setting. Most recently, we saw overall survival data at this year's ASCO annual meeting, and you can see that this is the first time that we're actually seeing an overall survival benefit with the use of an adjuvant targeted therapy in resected lung cancer, hazard ratio of 0.49. This is for patients with stage 2 to 3A disease. And then if we look at all included disease states, including 1B, 2, and 3A, you can see an overall survival again of 0.49. Overall survival benefit seemed to be across all subgroups. You can see sex, age, smoking history, race, as well as stage 1B and 2. You can see the confidence intervals kind of touch 1 for 1B and 2, and I think this is related to data not being mature. But regardless of adjuvant chemotherapy receipt, patients did benefit, and we'll talk a little bit more about this. Most of the patients, about 60% of the patients received adjuvant chemotherapy, about 40% did not. However, most of the higher stage patients, so if you look at stage 3, 80% of the patients with stage 3 did receive adjuvant chemotherapy. So in my practice, I'm going to continue to offer adjuvant chemotherapy because there is an overall survival advantage. Of course, I do want to give them osimertinib as well, but I'm not foregoing adjuvant chemotherapy. And then in terms of EGFR mutations, L858R did a little bit worse. I mean, they did benefit, but this has been known for many years based on the biology of these 2 mutations. Overall survival by disease stage is displayed here. And as you can see, stage 3A, significant improvement. You can see the separation of the curves is the most in stage 3A. And then, as we talked about a little bit, benefit was there irrespective of whether or not patients received adjuvant chemotherapy.